Welcome to Champion Health System, Oxford, North Carolina. In this video, Dr. Raj discussed venous disease and its significance. You'll learn how common this condition is, affecting nearly 30% of people, especially women, and why it should never be ignored. The video also explains why venous disease is not benign and emphasizes the importance of early diagnosis through tests like venous duplex studies. Understanding these signs can help prevent serious complications. Let's get into the video.
Okay, then. So let's go on talk about venous disease, which is most of the times we have some concept, but not a lot of concept, because this disease has more patients when compared to arterial disease. But for what the statistics shows that for every vascular disease that we see, we are missing 3 venous disease. And so the main thing here is, just like an artery, vein has 3 layers. They have an intima, which is inside, then media and adventitia. But in the intima, in arteries, you do not have valves other than the heart, but in veins, you do have valves. So when you think about a vein, how they normally are is there's a superficial vein which is connected to the deep vein through a perforating vein, and there's a deep vein. So usually the valves are pointing towards the heart so that it does not come back and pool in the legs. What is a varicose vein? They are the bulging, tortuous, and enlarged veins. Usually, when it's dilated, they are more than 3 millimeters, and they are, not every venous disease you will see visible varicose veins. That's the reason we do ultrasound. Under ultrasound, you could see these bulging varicose veins. And most patients, when they start with, they do have spider veins. These spider veins are very, very small. And within the spider veins, there are many categories, less than 1 millimeter, less than 2 millimeters, or 2 to 4 millimeters. There are many, many names for it. It's called telangiectasis, telangiectasis, reticular veins. And these veins are like weeds. What we see is not the real problem, but any of these small veins you have, they have a varicose veins under the skin, which is not visible. It's like a tree giving rise to branches, and what we see is the branches and leaves, and the real problem is underneath. And it mostly females affected when compared to males, but the Framingham study shows about 23% of males are also affected. Increased weight, multiparity, because when you have a big baby or multiparity, the baby comes through pelvis, and in the pelvis you have veins, and they get compressed when they are pushing through the pelvis. And also when the baby is lying there, they actually are obstructing the venous flow, and you could have varicose veins during pregnancy. And family history is a very important thing, because when one person in the family is having a varicose vein, there is a 60 to 70% chance there is another family member is affected. When there are 2 family members, the chance goes very close to 90% of having a varicose vein. And then activity level. If a patients are on their feet or they are sitting down in their desk for a long time, they have varicose veins. And this is one of the genetic disorder. It's called Klippel-Trenaunay syndrome. And this is one of the mutations where this is a congenital varicose veins. And this is a very difficult varicose vein, which needs a lot of treatments. So what are the symptoms of varicose veins? Tenderness, cramps, skin discoloration. You would have seen a lot of skin discoloration, itching. And patients can say fatigue or exercise intolerance. And I have seen in patients who have POTS syndrome, paroxysmal orthostatic tachycardia syndrome, patients having like dizziness and lightheadedness when they stand up. All these patients have a venous disease, because you need the blood returning back to the heart when you stand up to have these patients that doesn't have like a hypotension, venous hypotension. So All these patients have varicose veins or venous disease unless otherwise proven. And this is a classification. I don't want to go through it. I'll go through some pictures on this. So you could see, commonly we use a classification called a CAP classification. This is a clinical, theological, anatomical, and pathological. So CEAP score. So we go from C0 to C6. And anything more than C3, which is C4, C5, and C6, which are discoloration, ulcers or healed ulcers, we suspect patient may have May-Turner syndrome, where the vein is getting compressed by the artery. So if you think about it, and anatomy wise, actually the vein gets compressed between the iliac artery and spine, the back, just like a sandwich. It just compresses it, and that's the May-Turner syndrome. The initial that you could see is swelling. If a patient has a leg swelling and patient does not have a congestive heart failure, these patients have venous disease unless proven otherwise. Patient can have a diastolic heart failure or congestive heart failure. Sometimes they can have both. They can have heart failure along with venous disease. And I have to tell you that just because the patient does not have a varicose vein, it does not mean they do not have varicose veins. Discoloration, ulcers, and venous duplex, you can do the anatomy. So this is the differential diagnosis, the lymphedema. And also I'll go a little bit more on lymphedema. Unless there is a reason for lymphedema, in tropical countries, you could have an elephantiasis, which is a disease of obstruction of lymphatics. But in the US, majority of lymphedema is because of venous insufficiency. When the venous insufficiency has not been treated by most of our doctors, they leave these patients to have some puffiness in the leg, and then they go to. So initially there is a venous congestion. What happens when the vein is unable to take the blood back to the heart? Now the lymphatic system gets overwhelmed, and when the lymphatic system gets overwhelmed, now patient starts getting lymphedema, which is a stage of leg swelling. So even if a patient comes to your clinic with lymphedema, I would still do a venous duplex and stop, at least get the venous insufficiency fixed, so that the legs can get slowly smaller, but we cannot fully reverse it. You have a question? Okay. So what we do is we do multiple treatments. One is we do a treatment called, first thing is conservative treatment, like compression stockings, leg elevation, and pain medications. Even though this is like a band-aid. Once they have an anatomical problem in varicose vein, which is like the veins are not really carrying the blood back to the heart, nothing can stop them from getting worse. And just by wearing the stockings, you can slow them down, but it is not the fixation of the problem. Because this is an anatomical problem, it needs anatomical treatment. What we do is sclerotherapy or vein ablations. Only by doing this, patient can get better. You cannot reverse the venous insufficiency by just stockings alone. And so as I said, there are multiple types of ablations. We do laser, radio frequency, chemical ablations, or pharmacomechanical treatment called Clary-Vein. We also do ambulatory phlebectomy, saphenous vein ligation, saphenous vein reversal. And these treatments are not like in the past, they had a very gross surgeries. And now these treatments are so much outpatient based, does not take more than 5 or 10 minutes for the patients. And patients can walk in and walk out of the clinic and can go back to work on the same day. So for all the vein treatments, we tell the patients, you can take any medications you can, even the blood thinners, even warfarin can be taken. And these treatments can be done on warfarin, on Eliquis, on Xarelto, on Plavix. So please do not tell the patient they need to stop any medications. And just like the heart, the main pump of the body, so for the foot, it's a calf muscle. The calf muscle is very, very important for the veins to pump the blood back to the heart. The patients can have calf muscle failure if they do not exercise. They do not use their calf muscle, just like, say, patients are bedridden, or the patients are like sitting down in the office desk, just like a receptionist or a Walmart worker, or even us. Many of us do not move. They have problem with calf muscle failure and start getting the varicose veins. And if you see the valves, these are the valves which prevent reflux. And when they are usually a bicuspid valve, and they try to avoid blood moving, because you have a heart which pumps the blood, it goes to the foot. And what makes the blood come back to the heart? It is your calf muscle moving it. And when the heart relaxes, it actually sucks the blood from the foot towards the heart, but the suction power is not enough. So that's a reason, we have been created with valves in the veins, and these valves slowly move the blood back to the heart. If the patient has varicose veins or venous insufficiency, the patient's blood comes down, but it does not go back to the heart. And that makes the oxygen gets depleted in the leg. When the oxygen gets depleted, you can have, the skin starts dying because there's less oxygen in the tissues in the leg, and patients can have less oxygen. Then you can see discoloration in the legs, and you can see hemosiderin deposition, which is because blood stays there for a long time, you can have this discoloration. And third thing is, because of the less oxygen, bacteria grows much faster. When you have a more bacteria, they can have cellulitis, because you can do Bactrim, you can do all the antibiotics. It's not going to help them if you're not going to be treating their underlying problem. The underlying problem is venous insufficiency. So you have a petri dish where you are making the bacterial growth a lot. So these bacterial growth will get better if you can take care of the venous disease. And as the disease progresses, you can have venous ulceration, because the skin has less oxygen and they will die. So there are many, these are some anatomy. I don't know whether you really need to know it, but this time just talking about the veins, great saphenous vein, which starts from the origin, the groin, and it terminates anterior to the medial malleolus. So these are the superficial veins. We have a lot of veins in the body. These are the veins which actually causes trouble. If we fix them, they get much better. Next one is a small saphenous vein, which runs from the popliteal artery to the posterior side of the lateral malleolus. And we also have anterior accessory saphenous vein, which is in the front of the thigh, and we have posterior accessory saphenous vein, circumflex vein. Competent veins should not have any reflux. Anything more than 0.5 seconds is pathologic. And as we told in the past, pain, cramping, discomfort, itching, burning, restless legs, heaviness, redness, warmth, swelling. These are all symptoms of varicose veins. Patients may say that I am feeling so tired all the time. The main reason is the blood is not returning back to the heart, so they are feeling tired. And what are the risk factors? Any family history of venous disease, DVT, or injury to the legs, pregnancy, overweight, female sex, sitting or standing for a long periods of time, hormone replacement therapy, even tobacco products, even though it only affects arterial, but it also can cause problem. What are the complications they can have? Okay, the patients may ask you, okay, doc, I have varicose veins. What is it going to do to me? There are many things can happen. One thing, you can have cellulitis. Two, patient can have superficial thrombophlebitis. They can even have deep vein thrombosis, because the blood does not move. Moving water does not stagnant, does not sediment. Not moving, if the blood does not move, you can have a higher risk of thrombosis and pulmonary embolism. You can have lymphedema, and you can have venous ulceration, there are a lot of complications. Venous disease is not benign. That's the main thing I'm trying to emphasize here. Venous disease is not benign. It's better to treat them. Just because a patient is non-compliant with the stockings, try to put stockings every day. As a doctor, as a provider, would you be able to put stockings every day? Patients have arthritis in their hands. They cannot put stockings all the time. And even us, we are not going to be compliant. The main thing is you can try to tell the patients, keep the legs elevated in stockings, but at the end of the day, patient needs treatment. Patient needs ablation or deep vein needs to be fixed. So these are all the different stages of vein disease. You can have just the discoloration, swelling, hyperpigmentation, eczema, wounds, all these things in the leg. We go from C class 1 to 6. So this is C class 1. You don't have signs or any venous disease, but these patients have risk factors. They are starting there. The first C1, you can see the small veins. C2, varicose veins. You don't have to see visible veins, but they may have varicose veins under the skin. C3, edema, any kind of edema, pitting and non-pitting. Then you can have skin changes. You can have pigmentation, eczema, lipodermatosclerosis, atrophy blanchi, which is like a white color stuff here. So what is atrophy blanchi? Like a microthrombi. You have occlusion of small blood vessels in the deep dermis. It's all this, like, mostly because of the white cell trapping. And you can see this is the atrophy blanchi. If you see this is the patient has a vein disease. You can see this white color stuff there. The white color stuff here, this is all vein disease. Lipodermatosclerosis. This is hardening of the skin because of the panniculitis. This is all the affected lipid tissues, which is like a fat. You can see all different types of panniculitis, lipodermatosclerosis. It can be acute or it can be chronic. So if you have a chronic, you can see this wood-like skin, the darkish discoloration in the leg. And you have corona phlebectatia, which is a cutaneous sign. If you see this in a patient in the foot, this is a stage 4 disease. They are advanced disease. You don't want to say, hey, you only have this one. You don't have varicose vein. This is actually an advanced C4 disease. You could have venous cupping. You can have the small cups here. You can have a blue color telangiectasia. You can have red telangiectasia like this, and you can have stasis spots like a red color spots here. This is all in the foot. If you have it in the foot, because that's where it starts, and you can have a healed ulceration, and you can have this. I don't want to see this much. If we have taken care of these patients earlier, they would not have gotten in this situation. You only just say that, hey, we just poo-poo them. You just have a small edema, that is, give them Lasix. Lasix is not the treatment of edema all the time. Lasix, why do we need to give a Lasix on a patient just having swelling in the leg? What is the reason? We need to actually dig deeper. Do they have a Maternal syndrome, or do they have venous insufficiency? Do they have a heart failure? Lasix is not an answer for swelling in the leg. Okay. So this is what happens when we don't treat them. The lymphatics gets overwhelmed. Then there's a compromise in the immune system. You get a skin infection, inflammatory response, fibrosis. We don't want to see the patient at this stage. We would like to take care of them when they have small leg swelling. So when you see the leg, you can very easily differentiate between an arterial and venous. Arterial is usually in the toes or in the foot at the bottom of the heel, inside the heel. But usually venous ulceration is in the gaiter region. It's close to the malleolus. And how to prevent it? Managing high blood pressure, exercising for 30 minutes, 60 minutes, moving around, healthy with stress management. Okay, so treatment as venous reflex. Let's do patients with the renal. If you find a swelling in the leg, ask for a venous study with reflex, and we will try to find out if the patient has if you have a patient with C4, like any cellulitis, any patient if they have venous disease, if you see someone has small veins below the malleoli, you are in C4 stage. They need a venogram or the CT venogram and MR venogram are not needed, we will do a venogram in the office. So that's what it is. Thank you so much.